Good afternoon, everyone. I welcome you to this webinar on tackling the double-edged sword, sepsis and AMR. The next steps brought to you by Pfizer in association with ET HealthWorld. KNOW AMR is an initiative by Pfizer aimed at addressing the global problem of antimicrobial resistance. The initiative focuses on raising awareness, promoting research, implementing strategies to combat antimicrobial resistance, preserve the effectiveness of antimicrobial treatments. Today, AMR is turning out to be a challenge for global health security. With far-reaching consequences, more and more superbugs and pathogens that are resistant to antibiotics are creating double trouble for doctors who are helpless in the face of raging infections. It is turning out to be an inexplorable challenge in the treatment of sepsis. In this webinar, we will highlight the rising burden of sepsis and AMR with the importance of uniform and centralized system for identifying and reporting the condition. To take forward this crucial discussion, we have been joined by eminent doctors to address the critical issues and prevent sepsis and AMR from becoming a global threat across human, animal, plant, food, and environmental sectors. My name is Rashmi Mabian, and I will be the moderator for this session. So to take forward this important discussion today, we have been joined by our esteemed panelists, starting with Dr. M N Sivakumar, Head Critical Care Department at Royalcare Hospital, Dr. Ravikanth Porval, Consultant in Infectious Disease at Manipal Hospital, Dr. Rajib Paul, Senior Consultant, Internal Medicine at Apollo Hospitals, and Dr. Soutik Panda, Consultant and in charge Critical Care Medicine at Woodlands Multispeciality Hospital. Thank you all for joining in. So a quick message for all the audience before we begin. At any point during the discussion, audience can type their questions in the chat box, and we will try to answer as many questions as we can towards the end of the session. So quickly starting with the panel discussion, my first question is for Dr. Ravikanth. How can new and rapid diagnostic tools reduce unnecessary use of antimicrobials?
Yeah, thank you, Rashmi, for your nice words of introduction. I think it's a very important and very useful question of today's world. The two important difficulties which we face while treating our sicker patients are that, first of all, most of these patients are pre-treated at some center, either in form of outpatient or in form of some secondary or tertiary care center, and then eventually they reach to a bigger ICU where they are actually referred for management. Second thing is most of our traditional diagnostics which we have to diagnose the etiologic factors or the cause of the sepsis are not very specific or they are poorly sensitive, and they take time, and time is money for these severely sick septic patients, where actually we need to have rapid decision making so that we can decide about the life-saving drugs called antimicrobials in form of antibiotics or antifungals. So that's where the bigger challenge we face by the use of traditional methods. But thankfully, now we have availability of molecular tests like multiplex PCR, point of care tests, where the turnaround time is very short, probably few minutes to few hours, and you will be getting your results in these patients. For example, if you have a patient in your ICU and you have sent some blood cultures which is positive, in a traditional way, probably by the end of 48 hours or probably 96 hours, you will be able to know which bug it is growing and what drug it is going to be sensitive. But with the use of these newer advanced diagnostic tests, that 96 hours or probably 48 hours can be reduced up to 12 to 24 hours. So it actually helps in treating these sicker patients, actually, when you know what is the pathogen which is responsible for that, and also what is the resistance mechanism behind that pathogen, which we are not able to delineate if we use those standard methods. Secondly, I also would like to point out, apart from this availability and access to these newer methods, eventually we are actually causing a less collateral damage to our patients, which means not many antimicrobials they will be on. You will be able to de-escalate, escalate, or optimize these antimicrobials in these patients. So it is significantly helpful for current day and age.
Okay. Your views, Dr. Rajiv?
I completely second what Dr. Ravikanth was talking about the use of rapid diagnostic tests. Being a senior physician, it also helps me triage my patients much better in the emergency department. When the patients turn up nowadays with this influenza pandemic going on, and patients are coming to the emergency with fever for a few days, and just in the emergency only we're able to diagnose it's a viral, and many times just no use of antibiotics are started in such patients. Otherwise, in the previous days, any patient coming to the emergency with a high fever of 102, 103 would be definitely put on some antibiotics. Rapid diagnostic tests, like which we are doing, the respiratory panels or pneumonia panels, are helping us quickly identifying virus versus bacteria. Even similar for stool infection. I mean, many of the previous use, in a community, so much use of medicines like ciprofloxacin, metronidazole goes on. Anyone with a diarrhea just gets a combination of this or some other combinations. Now we are having patients coming to the emergency or admitting with diarrhea, and we have stool diagnostic tests which tell us it's just a rotavirus diarrhea. We just start with IV fluids, manage the patient with fluids and some basic management for diarrhea, and the patient is saved of using antibiotics. Lot of collateral damage is being saved. Lot of patients, the resistance of the inherent resistance with the patient develops. His own gut bacteria are saved from harmful antibiotics. In the long term, the gut bacteria are saved from becoming resistant. So rapid diagnostic tests definitely are the going forward. People argue they are not the gold standards. Obviously, they will not be the gold standards because they are based on PCR techniques. Obviously, some false positives always will be there. So, but in a given scenario, a good clinician, many times, even in the ICU also, specimens from the ICU, fecal samples, specimen for respiratory samples, the good clinician in discussion with a microbiologist or an infectious disease specialist can easily tell if 2-3 bacteria or viruses are growing in a sample, which is the most possible one, and tailor the antibiotic or the treatment modality based on that. And the resistance pattern is another very important thing which this diagnostic tools are giving us. Head on, we are very quickly knowing that it's a bug which is resistant or not resistant before waiting for the sensitivity patterns. So it helps us immediately escalating or de-escalating the medicines, and again leading to quicker recoveries and better management of patients. So overall, this new diagnostic policy things actually helps us in a significant way. And we are actually thinking of using it as a self-surveillance system in the future of infections in the hospital. Maybe we're still away from it, but we'll do it.
Really happy to know that there are things that are coming up which doctors are really happy with. So going on to the next question, my question is to you, Dr. Soutik. What are the measures that must be taken to use existing antimicrobials better?
Yeah, very good afternoon, Rashmi, and very good afternoon to all my fellow panelists and all of you who are listening to this webcast. See, I'd just like to add a few more points from what Dr. Rajiv has already mentioned, and thereafter I'm going to take my own question. That is, obviously, yes, all these rapid diagnostic tests have definitely made our life a little easier. Because as you know that we all start with a very broad spectrum antibiotic support whenever the patient of sepsis comes to us after sending relevant cultures. Remember that these rapid diagnostic tests are genotypic tests, but we are still sending the conventional phenotypic test, that is the blood cultures and the urine cultures and the respiratory secretion cultures, and obviously they take some time so that we can get the results. And this genotypic test, the turnaround time has been correctly said that it's just a 1 hour or so. And by that time, we obviously get to know about the possible pathogen. But having said that, they give us a list of broad probable pathogens. Now, out of that, you have to read that in the context of the clinical picture of the patient. So a focused clinical history still remains very important, because whether the patient is coming directly from the community or the patient has already got treatment in some other facility and from there the patient has got transferred to your center, or the patient has been there in your center for some time and thereafter the patient got transferred to the ward because of some criticality or eventuality that has happened in the ward setting, and for that the patient has come to the ICU. So that means that the patient has been in the hospital for some time. So you have to read those tests having that clinical relevance, so that you get to know what are the possible bugs that are the offending bugs, so that you can differentiate well between the colonizers or the commensals with the probable pathogens. And also there are some organisms which have got which are more vulnerable in some patients who have got those risk factors to get all those pathogens. So you read these tests under keeping all this context in your mind. Now, coming back to your question, that as I told you, that we start with a very broad spectrum antibiotic support whenever the patient comes to us. The Surviving Sepsis Campaign Guideline, a text which has been considered to be as sacrosanct by all of us. So we start with a very broad spectrum, and thereafter, once we get the culture reports, because not every one of us have the luxury of all these multiplex PCRs in our center. Obviously, I'm glad that I have got that support, but think about the tier 2 and the tier 3 cities, or even the doctors who are practicing in the far-flung districts of India. So they do not have those multiplex PCRs yet to have those multiplex PCRs with them. So they are still relying on this conventional phenotypic tests. They send in cultures, start a broad spectrum antibiotic therapy. Once the culture reports are available, only then they have that facility to narrow down the spectrum. And as you all know, that the antibiotic supply pipeline has gone dry. So since the 1920s, when penicillin was discovered, earlier to that, we used to say that people were living in a pre-antibiotic era. And now when in 2023, we are talking about colistin resistance. So we have actually arrived at the post-antibiotic era now. And the Infectious Disease Society of America, the IDSA, has already started ringing the alarm bell that there are these superbugs which are resistant to all the possible antibiotics which we have now at present in our armamentarium. So obviously the antibiotic usage has to be done very, very judiciously. So the optimizing the dose and the duration of therapy, and obviously de-escalation, timely de-escalation, depending upon not only on the laboratory parameters, but your clinical eye. You have to stand there at the bedside and judge whether the patient is doing well, getting better, or getting worse. So depending on that, you plan about escalation or de-escalation standing there at the bedside. So by those, everything taken together, the laboratory parameters and the clinical parameters, you think about early de-escalation so that you don't bring forward those problems of emerging drug resistance. You don't contribute to that problem of emerging drug resistance. So that way, you go ahead with it. Obviously, these multiplex PCRs have definitely helped us because you get to know the resistance pattern, and that way you can optimize the therapy even better within the first 1 hour. That is most important. A clinically relevant time, because time is important for us. Unnecessarily exposing the patient to broad spectrum therapy for almost 24 to 48 hours till the time you get the results of the conventional cultures, the phenotypic tests. With this genotypic tests, you get to know about the resistance patterns quickly so that you can narrow down the spectrum quickly. So maybe these tests are expensive, but if you look at the long term, you are actually reducing the cost by giving targeted therapy very early in the course of treatment. So in that way, you are actually reducing the cost of antibiotic therapy, and overall, you are reducing the length of stay in the ICU, and that way you are actually.
My next question is going to be taking responsibility of AMRs, all the doctors. How are hospitals balancing sepsis improvement and AMS programs, and what are its do's and don'ts that must be adhered to? So I'd like to start with Dr. Sivakumar.
If you ask me rightly, I think we are not doing it very appropriately. I think there is a huge variability in the way it is done in developing and developed countries. And in countries like India, which is a very large country, there's a huge difference. And there is a difference between private and public sectors as well. So the way the sepsis is managed or the awareness about AMR, there is a huge variability is there. But things are getting better thanks to all these accreditation agencies. And now most of the, at least the private hospitals are part of the accreditation. So they've made it mandatory to look at these aspects. So basically, if you look at both sepsis and AMR, you need to prevent infections whenever possible. And whenever you feel there is a infection, I think you need to identify them at the earliest, treat them appropriately, and put them on right antibiotics. I think that is the whole gist of it. But there is not much of huge awareness inside the hospital, outside the hospital, in the community with regard to sepsis or AMR. When you compare this to a myocardial infarction, or when compared to a stroke, I think inside the hospital and in the community, there is a huge awareness with regard to stroke, with regard to heart attack. So every patient knows it. Even in the hospital, the ER paramedic knows it. So they identify these things early, they treat them appropriately. But when it comes to sepsis, I think there is a huge lacuna even in the community, and even in the comes to an hospital, there is a bit of lacuna with regard to early identification, treating them appropriately. So I think you would have heard of code blues or code strokes. So whenever these patients comes to ER, but we don't have similar kind of awareness for sepsis. So the overall, the awareness, the public education, all needs to improve. I think things are getting better, but I think still a lot needs to be done.
Okay, Dr. Rajib, your views.
Yeah, sepsis, as correctly said, is a pretty challenging situation, keeping in mind the myriad presentation that it would come with. A chest pain of an acute myocardial infarction, most of the time it presents chest pain, or a milder, very different variations of it. Not classically, it would never present with a headache, but sepsis could just present with a meningitis, could present with a headache. So sepsis can form just a patient who is drowsy at home for last 3 days, who is not eating well. Say 75-year-old guy who is diabetic and not eating well and a little sleepy in the at home is probably a case of sepsis, or he could have just overdosed on some medications. So sepsis is kind of very myriad presentations, very difficult to many times diagnose, and that's one of the reasons why sepsis diagnosis is even delayed in the hospital itself. Even patients admitted in the hospital may develop a new onset infections or sepsis, and by the time it's picked up or action is taken aggressively, it's maybe sometimes late. But fortunately, things are getting better. And in a part of the accreditation process, or whatever we call it, ultimately, development of pathways have helped us. Like we are talking of the stroke pathways, the myocardial infarction pathways. We have also have now developing the sepsis pathways. The basic idea of creating a sepsis pathway in hospital is to make the junior doctors or the forefront doctors who are working in emergencies on the floors, wards, to identify some of the features which could indicate a sepsis. A patient comes to the emergency, if you have a sepsis pathway which lists some basic checklists, the doctor who is working new joining doctor in the emergency may pick up a few cases much more than previous other patient, some other doctors. So the pathway is what we are implemented in our hospital, and it's helping us in identifying many patients. Yes, there's a downtrend of it. We may be categorizing more patients in sepsis, but obviously anything that you create a model will always have some variants which will not always fall into the complete gamut of it. But creating a sepsis pathway is where logical use of antimicrobials can be an example of a patient who comes with pulmonary edema, who also may have breathing problem, respiratory rate of high respiratory rate, and may also look high heart rate, high respiratory rate, and just because it doesn't have fever, but keeping the sepsis pathway, which previously people used to use the sepsis criteria, it would automatically fall into a sepsis. So creating some pathway will help us, the juniors, identify so that they start appropriate antibiotics. At least antibiotics to be started within the first 1 hour to 6 hours. Is for septic shock, we say it's 1 hour. For sepsis, there's still some time for them to start. So the junior doctor starts. And second thing which hospitals should also basically do, which I feel, is creating a area-specific antibiotic policies. Very clearly, the microbiology, the ID, the physicians all should get together and create antimicrobial policies tailored to particular areas. A cardiothoracic unit versus a surgical unit versus a medical unit versus emergency room. So if a patient comes with emergency or in septic shock, which we say, and it's come from a possibly out another hospital, what is being treated, or nursing home is treated, we by default right now the workhorse antibiotic is carbapenems. So that's what some type of guidelines to the junior doctors so that they don't waste time and give some inappropriate medicines. So creating a sepsis pathway which also incorporates antibiotic policy, which the emergency doctors or the first responder will be able to know, okay, this patient is in septic shock, my first choice of antibiotic will be a carbapenem. This patient is in sepsis but not in septic shock, so I'll choose a different antibiotic. That will guideline will help definitely improve the antibiotic adherence, compliance, as well as correct selection of antibiotics. And again, rapid diagnostic tool, which I was talking about in the first, many patients now coming in the emergency, as I told, influenza with fever, high-grade fever. So, some may be having tachycardia, tachypnea. And then if you have the diagnostic test within 4 hours, I know this influenza and I don't need to start an antibiotic. Even my junior now knows that, okay, this is influenza, we just need to triage the patient properly and appropriately shift to ICU or room based on that triaging, and not just jump and start some high antibiotic just because he's having a high fever. So sepsis will have to have a pathway. We'll have to have some sort of a surveillance from the doctors, senior doctors, as well as the administrators, and also have some antibiotics or some antimicrobial policies, which if you have this balance and then go back to your data on a regular basis and see how it could be every 6 months, 3 months, or yearly, whatever your institution wants, and go back and see how you can improve your system. Definitely, we have improved our antimicrobial use by doing all these things in the last few years.
Dr. Ravikanth, what are your views on the do's and don'ts in balancing the sepsis improvement and AMS program?
Yeah, basically, look, one thing I want to make as a statement that antimicrobial resistance, if we really want to reduce it, it's not an overnight phenomenon. It's a journey. So there has to be an ecosystem where everybody has to be the part. And as my earlier panelists and speakers have mentioned beautifully, that there has to be early detection of the sepsis. There has to be a correct and appropriate treatment of sepsis. And then in the heart of it, there is antimicrobial stewardship. So when we talk about stewardship, there are two different types of stewardship. One is diagnostic stewardship, where we are only talking about identifying the correct patient, either by developing a specific pathways or by bundles, or by employing the newer diagnostic modalities so that we diagnose these patients little early into the disease. And then there is a therapeutic stewardship, where we are talking about selecting a right patient and giving that particular patient a right drug in right dose and for a right duration. There are 3 R which are important as part of therapeutic stewardship is concerned. But when you talk about balancing it into the hospital, so that's where the role of ecosystem comes into play. It's not a job simply being done by clinicians. There has to be a equally incorporation in decision making and support about these specific programs by hospital administration, because you definitely need hospital administration by your side if you really want effective antimicrobial stewardship to be implemented in your hospital. And only if you have an effective AMS program in your hospital, then only you will be able to see that kind of impact on antimicrobial resistance in your specific setting where you are practicing. For example, I would like to give you example of mine. About a decade ago, I joined my hospital, and that time I was a young budding infectious disease physician. So I wanted to roll out my AMS program. I wasn't very experienced about how to roll about it. And I was kind of a theoretical, bookish guy. I wanted to employ each and every part of AMS program, and I have no hesitation in saying that twice I miserably failed because the ecosystem wasn't ready. The clinicians was not ready. The administration was not ready. I want to do a restriction at formulary end, and then people perceived it as that I am going to control their prescription. And administration was seeing that what is it happening? It would actually disrupt the harmony among the clinicians. So you definitely need to see specific areas of challenge in in your specific setting where you are practicing, and then build a trust among the entire stakeholders of the AMS program. I can proudly say that I have implemented since last 5-6 years this AMS program in my hospital, and I am seeing a dramatic change in antimicrobial resistance pattern in my hospital. Uh, we have seen so many areas where drugs were given just like that, like Dr. Raji was mentioning, and now we have a significant rationalizing when all these antimicrobials are prescribed. So I think it's not only one person job. I would say it's a teamwork. Everybody has to contribute if you really want to balance these factors into your hospital.
Okay, so your quick views, Dr. Shautik.
Well, see, I'll just echo what the other panelists have said so far. Just I'd like to highlight one particular point, because there are a lot of stakeholders in this, and we doctors should not be the only one to be careful about antimicrobial stewardship and all. The policymakers in the government, they should also be very, very careful, because see, nobody is talking about the rampant use of antibiotics in animal farming. For example, Denmark was the first country. I'm sorry, Sweden was the first country way back in the mid of 1980s, where they stopped the extensive use of antibiotics in animal farming, where antibiotics are being used as growth promoters, so that they grow up well. These animals grow up well. They produce more flesh, and so that they can sell this stuff in the market very fast. And post 2006, the entire European Union banned use of antibiotics as growth promoters in animal farming. But there still has not been a very, very strong decision from our policymakers sitting in the government regarding usage of antibiotics as growth promoters in animal farming. In 2013, we had this Chennai Declaration. Post that, there has been some restrictions in issuing antibiotics without a prescription. If you now go to a medicine shop, they usually don't give you antibiotics without a prescription. So I'm talking about all these factors which are responsible for the emerging I'm not only talking about the antibiotic stewardship program that should be there in every hospital. That has to be there. But what about the people who are sitting in the government? They must also take into account of all this. And as I told you, usage of antibiotics in animal farming has to stop as a growth promoter, because that is actually, in a way, is also promoting to antimicrobial resistance in the community.
Very important point raised there. So my next question is also
Reshmi,
yes.
If you could permit, I think just a quick add-on. Since you specifically asked about how do you balance between the management of sepsis and the AMR, I think this is very important, because on the one hand, we all know that sepsis has to be identified early and treated appropriately. So we always traditionally say that you hit hard, hit early. That means you try to use a higher end antibiotics at the outset. So that is on the one hand. On the other hand, you very well know that this kind of usage is going to cause antimicrobial resistance. So how do you balance these two? I think as my co-panelists mentioned, that few things are very important. One, I think one of my co-panelists said that you need to look at the history. So when the patient comes, it is not bacterial, it is probably a viral lower respiratory tract infection. You can avoid an antibiotic at that point of time. Many of times it could be a non-infectious cause. So we need not jump and start an antibiotic. Sometimes you would have started an antibiotic just down the line after 48 hours. Once you get the cultures, you will know that is not an infection. So probably you should not hesitate to stop the antibiotics. So these are certain ways. I think not starting it when there is no need, or stopping it whenever you know it is not an infection. So these things are crucial, and this will balance between the sepsis management and probably between the development of antimicrobial resistance. So since I think earlier guidelines told us hit hard, hit early, I think probably sometimes we tend to overdo that. That's why the recent sepsis guideline says that if your patient is stable, if you still suspect sepsis, your blood pressure is stable, I think you can wait for a few more tests and then decide before starting an antibiotic. So that's how you try to balance it out.
Thank you so much, sir. Very important point raised there. So my next question is for Dr. Shautik. How crucial is the need for developing evidence-based?
This is extremely important, because whatever guideline we have, they are from the West. ICMR has definitely given us a guideline regarding the usage of antibiotics, but they largely reflect the Infectious Disease Society guideline that has been given from the North of America. Now, Indian population, the Indian subset is definitely a little different, particularly people who are living in this southern and the Southeast Asian continent and so on. So we need to have our very own homegrown data. There is a dearth of Indian data. Whatever multi-center studies which have been done so far from our country, majority of the participating ICUs were from the private sector, and we have got very little data coming out of public sector hospitals. And some of the tertiary teaching hospitals in the country, they have done some good work, and they have given some data, but still it's not adequate enough to understand what's going on in the Indian population at large, because we have to know about the kind of bugs that we are growing in our own backyard. It is different definitely from what's happening in the West. The entire socioeconomic context is also different. And everything finally boils down to cost. Treating a patient in an Indian ICU in a tier 1 city like us, and multi-speciality hospital, it's a costly affair, and the insurance penetration is still up to only 2% of the Indian population, you must understand. So not many of the patients who are coming to us are adequately insured, so they have to finally pay from their pocket. So everything has got some consequences. So we need to have our own data to understand how good or bad the Indian patients are doing. And I'd just like to mention about 2 studies. That was the INDICAP study, which was done way back in, I think, 2009 and 10, and then it got published in 2011. Then 10 years down the line, they did an INDICAPS 2 study. These are 2 very large studies which have been done, but they are just a bird's eye view of what's going on in India, what are the things which are happening in the Indian ICU, and they are just a point prevalence study. So just to give you an idea about how we are dealing with our patient and what is our mortality, and it is actually the gram negatives which are troubling us more, in contrast to the gram positives which are there in the West. And our gram negatives are mostly carbapenem resistant, and when it comes to carbapenem resistance, we are mostly troubled with the beta lactamases and all, rather than the KPCs, which is more in the West. So these are some data which have definitely come out, but we need more and more Indian studies. And in this context, I'd like to tell you that the Indian Society of Critical Care Medicine has started doing a lot of well-designed randomized controlled trials involving multiple ICUs across the entire country. But then again, they are mostly the ICUs from the private sector. We have very little participation from the public hospitals, but still we have to wait for some time to see what the results are which are coming down, so that we have our own homegrown data, and we do not have to always wait for what's coming down from the West to see, so that we change our practice pattern accordingly.
Agreed, sir. I think most of the doctors would agree to your view. So moving on, the next question is, how can benchmarking data-driven support systems play an important role in tackling the burden of sepsis and AMR? This question is for Dr. Sivakumar.
I think benchmarking is very, very important, because as a typical Indian, I have an attitude that it is not my problem, or it is not in my ICU. I don't have antimicrobial resistance. I don't have infections in my ICU. I think this is the typical kind of attitude most of us have. But I would again reinforce that these accreditation agencies, whenever hospital we went for some kind of accreditation, like either a JCI or an NABH, so it is mandatory for us to look into our data. So we came to know what is our hand hygiene. We came to know what is our hospital infection rate. So we know our pneumonia rates, we know our UTI rates. So that way we started to understand what is our problem, and we try to see how we benchmark nationally or internationally. Or sometimes when these benchmarks are not there, then we try to have an institutional benchmark, and we periodically see that how do we perform. So I think this is very important. Unless you have some benchmark, so you don't know where do you stand, and probably, so unless you have that, you may not make steps to improve yourself. So these things are very important, and many things I think you don't have a national or international benchmark. Sometimes society tries to provide you a benchmark. If not available, probably you can have your own benchmark and try to perform and improve on it.
Okay. So, Dr. Ravikanth, in your practice, what is the impact of AMS, biomarkers, and advanced diagnostics in controlling AMR and sepsis?
Yeah, as I've told you earlier also that AMS rollout was very impactful in my setting, and when you actually do it efficiently with the involvement of each and every stakeholder, then definitely you will be able to see a significant change in your antimicrobial resistance. But I would say it has to be done in a meticulous way, where initially you take baby steps and then you build up on your challenges, so that mm, it is actually there on the ground. Because most of the times, what happens when I see in other different settings where the the feedback forms or the restriction forms are being filled up and nothing is being analyzed, and there is no tracker on the drug uses, consumption uses, then sometimes it becomes only an exercise. So I would say, if you really factor in all these important aspects of AMS efficiently, that definitely it is a very significant impact on your antimicrobial resistance.
Right.
Not only this, since you also mentioned about biomarkers, at the end of the day, we all want to use antimicrobial judiciously. So it's not that we want to deprive somebody with some drug, just because we are doing antimicrobial stewardship. No, we want to use a correct drug for a correct setting. So for that, definitely biomarkers, your AMS programs, and effective rollout of all the aspects of AMS is very, very important.
Right. Agreed, sir. So, your views, Dr. Rajiv, on the same question.
Antimicrobial stewardship is a very important part of, and that's what this actually another benchmark which should be established by all of us, along with our data that we collect in the ICU, hospital-acquired infections, ICU-acquired infections, and other hand washing. Every hospital should drive antimicrobial stewardship in a big way. The major reason why I said this is the only area where everyone gets involved into it, starting from your administrative head, your CEO, to the microbiologist, to the physician, to the surgeon, to the nurses. This is a group which is a diverse group, and this is where actually you collate your data, you authenticate your data, you understand your data, and formulate your policies, which ultimately will maximize or optimize, I would say not maximize, optimize the use of antimicrobials in a hospital. And not only optimizing that in the selection, the procurement, starting even procurement. So extension of antimicrobial stewardship would even involve the pharmacy, where the pharmacy needs to know which antimicrobials, what are the licensing authorities, which antimicrobials or which companies have a better licensing authorities, or who clear some, we have some checklist. So you can't have every X and Y drug, every drug that there are. If you take a meropenem, there will be 70, 80 brands of meropenem in the market. You just can't keep up all of them in the formulary, and you need to know what to keep. So extension of the antimicrobial stewardship from pharmacy comes in a big way to rationalize the top 3, top 4, whatever you select, so that your patients get not only the optimal drug, the optimal dose, and the nurses have to be trained by the whole team to give the duration. We do miss doses to be reported. Okay, the patient missed the dose because patient went to a CT scan, was stayed there for a few hours for some investigation, went to a surgery. So all this gets captured, and ultimately antimicrobial stewardship is the way forward for all hospitals, where basically you are actually understanding your hospital, how you are performing and how better you can perform. And I don't feel there should be any particular steward, which should be some particular person should head this. It should be a rotatory head, and each person of the group, it could be initially headed by a physician, subsequently by ID physician, subsequently by microbiologist, even a nursing head. The nursing superintendent of the hospital also can be a head for 6 months or so that you incorporate everyone into the team practice and ultimately own the system. And that's what's going to help you in a big way in the future.
Thank you, Dr. Rajiv. So the next question is, how are next-gen technologies like AI and ML being optimized in diagnosing sepsis and identifying antimicrobial susceptibilities? So would you like to take this, Dr. Sivakumar?
You want to particularly ask about the use of artificial intelligence and
ML being optimized in diagnosing sepsis and identifying antimicrobial susceptibilities.
okay. See, I don't have much of personal experience on that, but still I will share whatever. See, one is I think there are already algorithms in place to diagnose sepsis. This is based on patient's parameters, vital signs. I think these algorithms are put into place into your monitors and other things. So they will give an alert probably whenever you get a similar kind of patients with sepsis. So or someone in your ICU who's for some other illness, and probably based on the vital parameters, I think if you put these sepsis algorithm in place, probably this could identify a patient with sepsis. So this could be helpful in early identification of patients with sepsis. One. Second, as far as the technology, I think we have talked about a lot about the early diagnosis of sepsis with regard to PCR-based techniques or other rapid technological assessment. There are many available. I think my co-panelist briefed upon it. So we have PCR-based technologies, and we do use mass spectrometry-based technologies, and these are very helpful in early identification. So many a times, I think these patients are treated in an outside hospital, or sometimes they are in your ICU for a long time. So when they develop sepsis, probably you have to use multiple antibiotics. So cost associated with the antibiotics, adverse effect associated with the antibiotics, and antimicrobial resistance. So when you use these technologies, I think probably you could avoid using multiple antibiotics. Probably you could narrow down. So you know the organisms quite early. But till probably you might have to do the culture. Culture is the gold standard. You would wait for culture. But early identification through these mass spectrometry or through these PCR-based techniques will help to narrow down your organism, and probably you need not give a very broad spectrum antibiotics, multiple antibiotics. These are some of the application I could think of. Other than that, as far as the stewardship is concerned, is all about data. So you need to have your own institutional data. These data needs to be collated. You need to put back as a policy, and these policy need to be implemented, and this needs to be audited. So all this involves a lot of data. Probably collating this data, collecting this data, probably your information technology will play a large role in it.
Okay, so moving on to the next question. Could you share some key strategies that healthcare providers should follow to prevent and tackle AMR? Starting with you, Dr. Ravikanth.
Yeah, so I think there's one thing which I want to say, that each and every healthcare provider has to know in-depth knowledge about infectious syndromes, their causative pathogens, and antimicrobials.
Right.
What happens, unfortunately, in our traditional part of medicine training, we are given a lot of influence about other systems, cardiovascular systems, central nervous system cases, respiratory cases. Nobody gives too much of attention how to be treated any infectious disease scenario. And the irony is, the moment we enter into the private practice, or for that matter, the real world practice, a significant chunk of our practice is these acute care cases, where we'll be seeing infectious syndromes in terms of non-septic patients, less sick patients, to severely sick ICU septic patients. And that's where we sometimes use only mechanical knowledge, which we have gained while we were trainee, as resident, as fellow, or something like that. So each and every healthcare provider should have decent, reasonable knowledge about these different syndromes, what to do, and when not to use a specific drugs, what are the benefits. Not every drug can be used for every specific syndrome in specific location. So there are a lot of nuances actually when we use these drugs. Everybody understands about other aspects, but these finer nuances need to be understood. So this is my suggestion to each and every healthcare provider.
Okay. Your views, Dr. Soutik?
Yes, it's absolutely correct what Dr. Ravikanth has said, that we must have some knowledge about the drugs that we are using and the organisms, the antibiogram. Grow your own, develop your own antibiogram. You try to know about the bugs that you are growing in your backyard, in your own ICU. Get your own antibiogram. Avoid polytherapy as much as possible. Whenever possible, go ahead with a monotherapy that reduces the cost, reduces the chances of toxicity, reduces the chances of super infection, then all the complications which are associated with prolonged antibiotic therapy. So everyone should be aware of these facts, and there has to be an accountability and accountability for all the stakeholders. So you do a tracking, monitoring, surveillance, feedback, collect the data well, do an audit and discuss about the things which are going on in the ICU, and everybody should be on the same page. The primary physician has to be taken into account, because not every ICU in India is a closed ICU. See, I talked about the INDICAPS 2 study. What it revealed is that the mortality they found was much more in closed ICU as compared to in open ICU. They don't use the term open ICU anymore. They say that it's a hybrid ICU where the intensivists are taking care of the patient every day, but then again, they are taking feedbacks from all the specialities who are attending the patient. It's a multi-speciality kind of an approach. So every stakeholder must know that when to start the antibiotic, optimum dosage, and when to stop. And there has to be some monitoring system that should be in place in the hospital. There comes in the role of the infection control team who go there, attend the patient there at the bedside, pick up data from the bedside, so that they have an idea about when was this particular antibiotic started and how long they are planning to continue with this antibiotic. Then discuss everything with the physicians who are attending the patient, and make them aware about the kind of organisms that the ICU is growing over the period of last 6 months to 1 year, and take a consensus about the duration of therapy. So rely on clinical parameters, the septic biomarkers, particularly procalcitonin, wherein you're thinking about de-escalating, and that way you can take your stewardship program ahead. So there has to be an accountability for all.
Okay, Dr. Rajib, your views?
Basically, I would put it into very simple terms as creating a policy, implementing the policy, having surveillance that your policies are how the policies are being monitored, managed in the hospital, and auditing and improving on the policies. This is what, in short, will be the whole gamut of antimicrobial management in the hospital setup. The policies could be designed by a team, which could be, as I told you, a branch of your antimicrobial stewardship, infection control and prevention team. Auditing can be done by another team, which could comprise of the nursing team, also a group of physicians or junior doctors also be a good part of audit. So auditing, implementing the policy, and ultimately improving your policies will help in resistance management in the long term. And the whole idea of this thing is to involve as many sectors of the organization that you can. As we correctly told many speakers, antimicrobial stewardship or any sort of antimicrobial monitoring systems or antimicrobial use systems cannot be a center to a particular group of individuals or a particular subgroup of specialities. You can't say it is a part of the infection control, so it's because it's an infection, ID specialist and microbiologist responsible for it. A nurse also is responsible, and equally social worker or even a head person who is taking care of the patient at the bedside doesn't wash hands properly and touches the patient, leads to cross infections. So it has to be involving a multiple. That's where the whole challenge lies. And if you can incorporate multiple different specialties, disciplines, or sectors of the hospital, then the long term there is a better chance that you will be able to control in a better way.
Okay, thank you, Dr. Rajiv. Dr. Sivakumar, quick views, please.
See, two things. I think one, what Ravikanth said is very, very important. All clinicians, I think being a doctor does not guarantee you have a good knowledge about infectious disease or antimicrobials. I think all clinicians should have some basic knowledge about infectious disease and antibiotics. And as Dr. Rajib Paul said, probably having a policy, following the policy, and probably auditing your complaints. All these are very, very important. I want to just add two more things. One is culture. I think whenever we treat significant infections in an hospital setting, we tend to send culture. I think that is very, very important practice. The flip side of is don't send a culture when you don't think of an infection. Right? Many a times, I think we tend to send unnecessary cultures. So it will grow some organism and you tend to overuse antibiotics. So appropriate use of culture is very, very important. And the last one I would like to add is many a times, I think probably we, though we are specialists or super specialists, I think we are not good at treating infections. I think we need to take the help of infectious disease specialists like Dr. Ravikanth whenever appropriate. I think their approach and probably is totally different. So when you're treating severe infections, probably at least you should take specialist help. That makes a difference.
Okay, so we are going to be taking the last question now. This is for Dr. Ravikanth. How can we improve global surveillance of drug resistance and antimicrobial consumption?
Well, there are different methods available to do this. There are software systems. We call it WHONet system, which is approved by WHO, and there are various other systems. Actually, you can take help. Since you asked earlier by Dr. Sivakumar about AI and data, healthcare is something which is packed of data. There are a lot of data in healthcare. The only thing is there is no organization of that data. So, when you are talking about surveillance, surveillance can be done on various aspects. It could be drug consumption, it could be antimicrobial resistance, it could be your isolation practices, it could be your attitude toward prevention. There are a lot of other things which actually you can do in terms of surveillance. But yes, when specifically you ask about drug consumption and antimicrobial resistance, there are specific software systems which you can take help. And most of the microbiologists are very well versed about using these specific systems, and they are an integral part of infection control team, and they are actually regularly doing it. When it comes to the global surveillance system, I would say there is something we need to understand the difference what West has as compared to this part of the world. We have differences in terms of pathogens. We have gram-negative predominance as compared to gram-positive pathogen predominance in West. So we'll have to be little tweaking our our tracking, our importance when it comes to the surveillance. So there's no fun doing something which is less prevalent at our setting, and we are actually after that. So you'll have to tweak the setting actually where you are practicing.
Thank you. Thank you all the doctors. Now we will quickly go into the question and answer round. We have a few questions from the audience. Taking the first one, this is for Dr. Sivakumar. What is your view on preventing hospital-acquired infections like VAP using newish technologies like VAP care in reducing antibiotic use in the ICU, especially when these have strong data about infection prevention?
I think we all talked about infections and antimicrobial stewardship. I think the most important thing is one, preventing an infection from developing, and the second will be inside the hospital or inside the ICU setting, you don't want that to spread from one to the other. So basically here, infection control plays a huge role, and I'm sure I think you know that bundles is a group of interventions. When you try to put it together, they are more effective rather than practicing it alone. So for every of these hospital-acquired infections like urinary tract infections or pneumonia, you do have a prevention bundle. So I think better in your ICU, analyze what is your problem and what is leading to these infections, and you develop your own prevention bundle. So there are standardized pneumonia prevention bundle or urinary tract prevention bundle. But the important thing is, I think someone has to look at every ICU has a bundle in place, but you need to look at how you're compliant to this bundle. Someone on a daily basis has to look at the compliance to this bundle. That will help in better implementation of this bundle. So there are many things like you got a subglottic tubes with suction catheters, and there are newer kind of tubes which are silver coated. So some are validated, some you have a data, but some are still in a very early stages. But there are what you need to do is you need to do simple things right. You need to have a good hand hygiene. You need to have a head end of the bed elevated. You need to keep your oral hygiene good. and probably many other things like maintaining a cuff pressure of the endotracheal tube, like simple things. Probably, I think if you do it on a consistent basis, that goes a long way in preventing your VAP. But there are newer technologies coming up. Probably these technologies involves a cost, but when it is validated and proven, probably you could implement these technologies.
Okay, so the
But
next question, yeah.
what I would recommend is to each ICUs to have their own prevention bundle and probably look it on a day-to-day basis whether they are complying to it. That's very, very important. But I would recommend to do the basic things right. That's more important.
Okay, thank you. Thank you, Dr. Sivakumar. My next question is for Dr. Rajib. What kind of gap is there in early diagnosis and what kind of rapid detection methods are currently available?
I think we discussed in detail about the current rapid diagnostic methods, and we have lots of upcoming and already established rapid diagnostic tools, which incorporates most of the genetic testing, respiratory samples, throat samples, stool samples, and even blood culture identification samples. All are already tested and being used extensively in many top centers. Gaps, and also we have the point of care testing, which you have your malaria kit test, you have a dengue kit test. All these are readily available off the shelf nowadays. So the gaps, if you ask for the availability, these tests are easily available. Obviously, all centers don't have this test, only mostly in the tier 1 and some tier 2 cities will have availability of this test, mainly because the setup of this test would cost a little bit. However, long term, as we discussed, it will be beneficial for the whole community as well as the individual patient. The cost of the whole treatment will come down if used. Gaps, yes, the gaps are there. They are not the tests which are gold standard. A clinician, a good clinician will need to be required to interpret many of this data which comes from this tests of genetic tests of by bacteria. Respiratory samples showing 2-3 different viruses or a combination of bacteria growing in sample of a patient with pneumonia. It's a clinician which will have to identify, because being a genetic test, it will have to be ultimately based on the clinician or the microbiologist to identify the pathogen or the offending pathogen which lies the most common. Otherwise, you'll be running treating too many bacteria viruses based on this. So we have tests, we have them validated, they are helpful for us, but it's very important for somebody to use those tools correctly so that we don't overuse use of antimicrobials or too many treatments for simple patients.
Thank you, Dr. Rajib. And due to time constraints, we will not be able to take any further questions. Thank you, everyone, for joining us today for this knowledgeable discussion on tackling the double-edged sword of sepsis and AMR, brought to you by Pfizer as part of its KNOW AMR initiative in association with ET HealthWorld. I am sure we all have a lot of learnings and takeaways on the crucial measures and practices that help in reducing the risk of AMR and sepsis for enabling better care delivery. I thank the speakers for the valuable insights shared and to everyone for your time to attend this webinar. I wish you all the best in your AMS efforts. Together, we can take a pledge to educate ourselves and others about the causes and risks of sepsis and antimicrobial resistance and slow down its spread for a healthier tomorrow. Thank you, everyone.
Thank you.
Thank you. Thank you very much. And thank you to the audience who participated in this program.
Thank you. Thank you. Thank you, Rashmi.
Thanks and goodbye.